السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم المحاضرة أو الفيديو هيكون طويل شوية، لأن أنا غطيت فيه كل التريكات أو الكلينيكال بيرلز اللي أنت محتاجها عموما في البري ترانسبلانت بيري ترانسبلانت أند بوست ترانسبلانت اسسمنت أند مانجمنت. فنتوكل على الله إن شاء الله إن اليوم هنكون مغطين كل الحاجات اللي أنت تحتاجها في تحضير المريض ووقت العملية وبعد العملية وكل الداتا. ويا ريت وانت بتسمع الفيديو ده يكون معاك ورقة وقلم، او تحاول تسجل حد وتسجلها عندك وتعملها كبروتوكول عندك في المركز اللي انت فيه او السنتر اللي انت فيه، او تخليهم معاك لان ممكن تحتاجهم انت وانت منوب او مسؤول عن حالة ترانسبلانت ايزر بري اور بيري اور بوست ترانسبلانت. نتوكل على الله. بسم الله. بس هنراجع الكام الفيديو اللي فاتهم بس باختصار عشان نخش على المفيد اليوم. طبعا انت ما بيجي لك عيان اندستيجينال ديزيز بتشوف الديموغرافيك بتاع العيان، طبعا الحته بتاعت البيرسونال هيستوري بتاع العيان بالايج بالجندر بتاعه بالريس بالكلام ده كله، برايمري كidney ديزيز او برايمري رينال ديزيز او برايمري diagnosis فور end-stage ديزيز. ده important especially for some diseases with recurrence, and family history is important also. And date of dialysis initiation and duration، متى بدأ هو الغسيل بقاله كام سنة على الغسيل، دي بتفرق معاك في الاوت كام بتاعك. dialysis modality والبريسكريبشن بتاعته، علشان خاطر لازم كل العيانين قبل العملية ب 24 ساعة يكون عامل دياليسيس خلال آخر 24 ساعة قبل السيرجري. فاسكولار اكسس اند كومبليكيشن ده زي ما اتكلمنا عن الفيديوهات الماضيه، سواء كان تانل دياليسيس كاسيتر او بروتينيال دياليسيس كاسيتر. وبتشوف لو في حصل كلوتس او ثرومبوزس او مشاكل مع الدياليسيس او انفكشن او وات ايفر. ريزيدوال رينال فانكشن زي ما اتكلمنا عنها الفيديوهات اللي فاتت برضه، ريزيدوال كميه اليورين اللي الفاضله عند العين دي بتفرق معاك. طبعا بتفرق معاك يعني بطريقه لا تتخيلها لما تروح تشوف العيان بعد السيرجري. شوف لو كان العين مثلا انيوريك اور زيرو يورين and making 1 liter urine means it's good kidney function already, especially with living donor kidney transplantation. ميديكال هيستوري، سوشيال هيستوري، الكلام ده كله طبعا اتكلمنا عنه في المحاضرات السابقه بس بنراجعه اليوم. زي الباست ميديكال هيستوري بتاع العيان او الميديكال هيستوري او سيرجيكال هيستوري بتاع العيان عموما. دايابيتس بالكومبليكيشن، هايبرتنشن، جي ان، وات ايفر ايه الديزيز بتاعه كان ميديكال والدنيا ماشيه معاه والميديكيشن اللي ماشي عليها حاليا، وعنده الرجي ولا لا، عندي انتي كواجوليشن، عنده انتي بليتلت ماشي عليها ولا لا، هيحصل لها هتعمل مشاكل معايا خاصة لو العين على كلوبوديجريل او البلافكس. طبعا العين ده لازم يتكنسل، لازم يكون فري اوف بلافكس فور 5 دايز. لو عين على بيكسبان وارفرين حاليا بنعمله كونفرشن دورينج ادميشن، وان شاء الله نقدم توك سيبريت فور warfarin and apixaban or anticoagulation conversion once you are calling the patient for surgery. Functional status and exercise tolerance for mobility and hospitalization post-transplant. Social history, smoking, alcohol, drugs, occupation. For drug covering, and smoking and alcohol should be and recreational drug, all this should be stopped or quit before transplant surgery. Family history زي ما قلنا في kidney disease the most important family history for primary oxalosis or another any stone history in the family or genetic history for some GN diseases, cardiovascular, diabetes, cancer. All this will expect what is your patient outcome after transplant. Physical and cardiovascular assessment is the most vital part in your assessment for pre-transplant assessment for kidney transplant, especially with complete physical examination, included vital signs, body weight, BMI, volume assessment, nutrition for your patient, especially with albumin, cardiac as a marker, yeah, and cardiac symptoms, functional status, and ECG, echocardiogram, stress testing, and stress imaging, and angiography as recommended by cardiology. And you should have cardiology clearance for any recipient for kidney transplant. History of MI, congestive heart failure, arrhythmia, and revascularization for counseling before, during your workup for high risk of either acute coronary syndrome or arrhythmia peri-transplant surgery. Cardiology consultation, if indicated, is vital. And immunology, serology, imaging, history of sensitizing giving, like blood transfusion, pregnancy, previous transplant. These three can make your recipient have a lot of antibody in his serum, and this make him high risk of rejection. And it will be difficult to match a donor with him for final cross match. Sometimes came positive because this sensitizing event before. HLA typing and PRA cell-based and calculated. All this also is important to give you just idea what is the induction medication you will use, either ATG or basiliximab, as we spoke before in the previous talk. Donor-specific antibodies cross-match. This is important also to know, as we mentioned, just for induction and close monitoring after transplant, if any deterioration of the graft function, if any rejection or acute kidney injury. Serology, as we mentioned, the most important CMV and EBV in our serology screening, especially for CMV mismatch. As I told you before, CMV ABV mismatch means the donor positive, recipient negative, and these two patients should receive valganciclovir for 6 months. HIV is important screening, hepatitis C, hepatitis B. Hepatitis B should be immune. Hepatitis B surface antibody should be above 100, but above 10 for general population. But sometimes we accept patient receiving cycles or session from hepatitis B vaccine with above 10, it's okay. But the best is 100 as the guideline recommendation. Varicella should be immune, otherwise he should receive 2 varicella live vaccines before transplant, and 2 or 3 months between the 2 doses, and 1 month to be after the last dose to be ready for transplant. Once he receives the second dose, we should wait for 1 month to get clearance for kidney transplant. Imaging, chest X-ray, abdominal ultrasound, iliac Doppler, CT pelvis, MRA, especially for polycystic kidney disease to rule out magnetic resonant imaging or angio, just to rule out cerebral aneurysm, especially with patients with polycystic kidney disease. CBC, to be sure, not anemia, no leukocytosis, no thrombocytopenia, no need for hematology clearance or bone marrow biopsy before transplant. Coagulation profile also of any abnormalities, just to be sure, no need for hematology. Electrolytes, to be sure your patient controlled for calcium and potassium or whatever. Renal and liver panel to discover if any issue need GI clearance or other subspecialties. Bone mineral profile, albumin, iron studies if you need iron, and our plan to just to keep his hemoglobin above 100. Glucose, oral glucose, hemoglobin A1C, if diabetic or not, to predict the post-transplant diabetes. Cancer screening, PSA for male, PAP and mammogram for female. Also fecal occult blood and FIT test. If positive for both, you should go to colonoscopy for colon cancer screening before transplant. Other tests, pulmonary function test if you have patient with bronchial asthma, COPD, and endoscopy for any patient with suspected frequent vomiting, GI abscess, or any issue related to upper GI. Urology consult, especially for patient with any issue with his neurogenic bladder, or other patient with frequent UTI, patient with cyclophosphamide, we need to rule out hemorrhagic cystitis. All this maybe you need cystoscopy and urine cytology. And the TB testing also the most important to be sure your patient don't have latent TB. Maybe he will need just INH or rifampicin now as prophylaxis before transplant, or to be treated before transplant. Immediate pre-operative assessment just before the surgery. Just you should decide your patient will receive deceased or living donor, living either related or not related, as we spoke the last videos. And it's just a rapid review for the past medical history to be confirmed, no family history of renal disease, end-stage renal disease duration, and other comorbidities, and discuss the risk and of this outcome on his outcome for each recipient. Dialysis details, modality, duration, last session, and the complication. You should concentrate, make a part in your notes for dialysis, when he started, and what is the dialysis access, what is the complication, and when the last session, because we should dialyze the patient night of the day of the surgery, night before the day of the surgery, at least to be sure electrolytes and volume-wise patient you're optimized. Medication, antiplatelet, anticoagulation, allergy. Medication, if any patient antiplatelet, anticoagulation, we should just address this for conversion or just delay the surgery, especially on Plavix. Allergy for Septra, for example, patient allergy for trimethoprim, cotrimexazole. This patient should be addressed for what is the PGP prophylaxis, UTI prophylaxis post-transplant, and we'll come to this in separate talk. Either dapsone or atuvacone or bentamidine. Bentamidine is a good 300 milligram inhaler every 4 weeks, and atuvacone 1,500 PO daily for this, covering sometimes 1 year, 9 months, 6 months, according to your protocol. Current health, any recent infection, any recent antibiotic, any recent hospitalization, Any recent blood transfusion, all this should be asked once your patient admitted for transplant to confirm no active problem. And also cardiac workup, echo, stress, and you should be updated and you should get clearance from cardiology to be sure your patient from cardiovascular, because the most common cause of cardiovascular morbidity mortality either on dialysis or peri-transplant period is cardiovascular. Pulmonary assessment for infection, smoking, COPD, just to rule out any unaddressed any issue before transplant should be sent for maybe they need spirometry or need CPAP or need just respirology clearance, more workup, CT chest or whatever. Correct electrolytes, metabolic issues like hyperkalemia, decay, manage anticoagulation, anticoagulability, as we mentioned before, maybe sometimes need hematology clearance or thrombosis clinic clearance. Infectious prophylaxis, insulin infusion. If diabetic, we should arrange all this before. Infectious prophylaxis like antibiotic for surgery or other routine prophylaxis will come to this. Insulin infusion, especially for type 1 diabetes, and you should consult endocrinology for close monitoring peri-transplant surgery. Immediate post-operative assessment just to monitor hemodynamic. Once your patient came out of the surgery or in PACU or in recovery room, you will go to see the first thing you will look hemodynamic, blood pressure is okay, not hypotension, not severe hypertension, and respiratory status, your patient is stable, not brady, not tachy, and the level of consciousness, your patient is not agitated. Some patient came agitated after recovery. And because you will decide in recovery room or PACU, this patient should be transferred to either intermediate ICU unit or ICU bed. But you be sure in recovery room your patient is stable for transfer, or because sometimes the patient some be agitated, some patient level of consciousness not recover, some patients severely hypotension need aggressive ICU monitoring, and sometimes noradrenaline or inotropic support post surgery. Review the operative notes. Usually in the chart, you will see the anesthesia notes, see how much blood loss, how many complication with anastomosis, how many reconstruction, renal veins, renal artery, and how much blood loss. All this you should review in the chart of anesthesia. How much fluid given, 2 liter, 4 liter, or whatever, any Lasix given, any heparin given, any complication, what is the warm ischemia time during the surgery. Warm ischemia time from the time of taking the kidney, for example, for deceased kidney or from any kidney, just from the ice of box until declamping already. This is the warm ischemia time. And what is the graft appearance after declamping is important also. And how much urine output, especially if your patient have good residual renal function or zero urine output, how much urine back you now. Volume assessment, exam, CVB, fluid balance. Volume assessment is important in PACU in recovery room. To be sure your patient need fluid or no. Some patient just blood pressure, you will see 110, 100, and the patient is okay, chest is clear, no crackles, nothing. Just you can give 1 liter fluid. Don't give 200, 250 like a small cup like this. You can give 500 at least to 1 liter in the vacuum. If your patient received 4 liter and blood pressure, for example, 180, 160, you can give challenge of Lasix. Just don't play. You can give 120 milligram Lasix if no urine output. What is he? Don't afraid, don't afraid, because this patient he's not making urine. Don't worry from Lasix. Lasix is just a it will make like little bit some vasodilation. It will help with the kidney recovery also. If it's not making urine, as if it's not working for urine, it will work as a vasodilation for the kidney, for all blood vessels in the body. Usually we are starting 120 milligram and we can give another 120 after 1 hour if no response, and still if no urine, you should do ultrasound stat to be sure the kidney surgery and the vasculature all are okay without any thrombosis or complication, and to be sure the perfusion to your kidney is perfect. Low or no urine, just if no urine and the patient making some urine and after that no urine, just flush the Foley. And IV fluid, as I mentioned for you, diuretic, Doppler ultrasound, all this mentioned already. Review immunosuppression and prophylaxis to be sure. Calculate like calculating your finger in your hand. You should calculate to be sure immunosuppression prescribed by for the right patient, right dose, right time. Don't forget any immunosuppression, because sometimes we sometimes forget prophylaxis medication, sometimes forget one of the 3 pillars of immunosuppression, tacrolimus, MMF, and the prednisone. Daily, you should do stat lab in PACU included or routine lab, and some patient elderly, some patient needs ECG, troponin, and the daily blood work as needed, either ECG or surgical X-ray, other blood work like routine blood CBC, lights, creatinine, extended panels means all electrolytes including calcium, phosphorus, magnesium, albumin, and the liver function test as your protocol. And the postoperative order fluid analgesia imaging should be ordered to be sure everything is okay. Counseling risk benefit, this all this from before surgery. Just that you should, when you are sitting, we discussed this all in the last videos already. When you're sitting your patient for transplant workup recipient clinic, you will discuss what is the option now for end-stage renal disease, either dialysis or transplant. We have two types of dialysis, either hemodialysis or peritoneal dialysis. And the best treatment is transplant, but it's not cure. It's the best treatment, but not cure. Transplant, dialysis just give you 25% of the normal kidney function just for quality of life electrolytes and just keep your patient alive. But transplant will give you 50% because taking only one kidney, 50% of the normal kidney function, better quality of life, improve just long survival, travels, food, activity, social, it will be better than dialysis. And the type of donor, either deceased donor, living donor, living طبعا preferred if available. And success rate 1 year for living donor are above 95%, and for the deceased donor 85% 1 year, and after 5 years maybe 90 above 90% for living donor and 80% above 80% for the deceased donor, and you can subtract 10% of the second transplant. Short-term risk, as we mentioned, anesthesia surgery. We discussed all this before in the introduction talk. And the long-term risk, we discussed this in previous talk in details: infection, cancer, metabolic side effect, immunosuppression, drug, lifelong requirement. We discussed this in details, all immunosuppression. Kidney transplant, medical consent. This like how to, once your patient came for admission, now you need to let your patient sign consent, but you should be honest. You should لازم تكون صادق مع المريض بتاعك وتعرفه ايه الجنرال بنفيت للمريض على حسب الحاله بتاعته والاستاتس اللي انت عملتها والورك اب اللي انت شايفه. لازم تكون صادق مع المريض على بحيث ان هو يروح للعمليه ولا ما يروحش. لازم تقول له تبلغه بالجنرال بنفيت، سيرجيكال ميديكال ريسك، medication side effect, graft function risk, donor specific risk, post transplant expectation. You should be honest with your patient and his relative. I hope many relatives attend this two slides or these two talks or this two message for you. Otherwise, if anything happen bad after or not expected to be happen after transplant, at least you document all this with multiple family members. If one forgets, the other one will not forget, but at least to be honest. ولازم تكون صادق مع الله قبل ما تكون صادق كمان مع المريض يعني. General benefit, why transplant? Why we prefer transplant over dialysis? Why we mentioned already longer survival in comparison by dialysis and better quality of life, travel, eating, fluid, whatever, no more restriction for his potassium, phosphorus, or whatever, improved energy and daily functioning, returning to his work, and economic, everything is transplant is better than dialysis. No one have any suspicion about this, but transplant is the best treatment, not a cure. Surgical risk, you should also discuss it superficially, but this other job for the surgeon, he will discuss all this. But you should mention for your patient, you should expect bleeding, and maybe you need blood transfusion, some bruising around his wound. We saw a lot of the patient, and pain, you should maybe around 1 week or whatever. Sometimes just cutting small nerves, pain will persist for months after transplant. Nausea, vomiting. Some patient can tolerate the oral medication or anesthesia or hydromorphone or other MMF. All this can give side effect for this GI upset, nausea, vomiting. DVT, pulmonary embolism, little bit. You should explain for your patient and encourage mobility. Now we have this ERAS protocol, this enhanced recovery after surgery. You should ask or motivate or encourage your patient for mobility after transplant. We can use also elastic stocking or compression devices already for his lower limb, and plus encourage mobilization. And now the surgeon, most of the surgeon can start heparin. If no issue with the surgery, we can start heparin subcutaneous twice daily, 5,000 unit regular heparin. Cardiovascular or delta barin 2500 or 5000 whatever. And cardiovascular risk, you should be honest with your patient for MI, acute coronary syndrome, stroke, death. Also, if your patient high cardiovascular before during your workup with cardiovascular team. Medication side effect, you should remind your patient before the surgery. Don't forget immune suppression have a benefit to prevent rejection and keep your graft survivor longer. But on the other side, we have this immunosuppression side effect infection. We discussed this in details. Malignancy, especially skin, is 40 times higher risk than regular population. Lymphoma, 0.52%. Other cancers. Infection, we have a lot of infection already started from UTI, pneumonia, and all CMV, ABV, BK virus, or whatever. Other side effect like hypertension, it will be worsening, especially if your patient on multiple antihypertensive medication before. Sometimes, some patient may be out of the medication, some patient may need to add more medication, and hyperlipidemia, gout, and worsening diabetes. Sometimes tremors, headaches, seizures, all this related to tacrolimus. We can shift it to cyclosporin or shift to another emitters. Diabetes sometimes worsening from tacrolimus and steroid, and with decreasing the dose, maybe everything will be under control. But currently, we are discussing. I give you the last talk about diabetes post-transplant. Now, currently recommended just use empagliflozin, start 5 milligram and increase to 10 milligram, or Ozempic 0.25 milligrams subcutaneous weekly for 4 weeks, and you can increase to 0.5, 0.75, and 1 milligram weekly until you control your patient body weight and diabetes by these two medication plus metformin, linagliptin. I think patient in insulin, you can resume just his insulin and to be followed up by his primary care physician or diabetes or endocrinology. Steroid related, some issue with the steroid, just weight gain, skin thinning, cataract, osteoporosis, and common vascular necrosis. Graft function risk to the kidney. Sometimes you should mention for your wish to be honest. Sometimes the kidney not working, either from surgical problem or anastomosis or thrombosis or non-working, whatever. Some kidneys delayed graft function. If it's no issues ultrasound, some kidney will be just a delayed graft function, severe acute tubular necrosis. It will take times to recover. Some patient 1 day, some patient 2 days, some 1 week, 1 month, whatever. This depends on the warm ischemia time and the other comorbidity of the recipient. It's not hypotension. It's a major problem after transplant. If your recipient hypotension, no perfusion to the kidney will take long time and you need inotropic support to support the perfusion to your graft. Risk standard moderate high according to the risk addressing for your patient by HLA and whatever. Rejection risk 5 to 10% in first year. Little bit, just 5 to 10% in the first year, and survival, as we mentioned before, 1 year above 95 in living donor, and 5 years above 90. Disease risk recurrence. If your patient has some GN, it will be able for recurrence, especially for focal segmental glomerulosclerosis or other GN. Other patient specific risk factors is depend on the other patient comorbidities. Already you should explain every point in your patient in details, especially if your patient obese, and this will delay his wound healing, more risk for infection and delayed graft function. Donor-related consideration, especially for CMV CMV HBV mismatch means that the donor positive and your recipient is negative. This means a mismatch. You should give prophylaxis here 9 months for Valgan, cyclovir, plus close monitoring after transplant according to your program protocol. ECD consent. ECD means extended criteria donor, and we explained this before. ECD more than 60 years or less than 60 with hypertension or CVA or some renal impairment. Exceptional distribution donor. This is a donor with unknown physical, sexual, or infectious history. You should just let your donor sign consent, but usually not usually, this is mandatory. You screen your patient by NAT testing, NAT nuclear assay testing for hepatitis B, C, HIV, and should be negative. If anyone positive, you should inform your donor. Have the, especially for hepatitis C, if he's agreed to receive this kidney and receive treatment, full course of treatment with Maveret, this is for the donor. He should accept this idea already. Donor with significant allergy, I think this is not important. And left after surgery, this patient he should have regular follow-up and lab monitoring, and we'll discuss this by the last two slides today. Transport to whatever your hospital in the first week. Transportation to be sure your patient have transportation to your hospital. Medication adherence is critical. You should stress in the medication adherence, especially for young, and one with no family support. This is the most important. To be sure your patient will be adherent to his medication, and you should explain and educate and be sure before discharge from hospital your patient know his medication times, doses, and you should anticipate discharge date after day 1 or 2 from your patient and the kidney or graft function. Benefit out risk for most of the patient for transplant is the best treatment but not cure. Informed consent you should be signed, and patient family must understand follow-up requirement and surgery, medication, graft risk, donor specific issues, consent confirmed and documented all your staff. Now pre-operative plan. انت دلوقتي العيان بتاعك انت هتستعمل له ادميشن دلوقتي. ايه البلان بتاعك لما تيجي تعمل عيان ادميشن دلوقتي؟ بقول لك يا دكتور اكس، انت جالك المريض اكس ولا جالك المريض زد دلوقتي انه فور ادميشن فور ترانسبلانت. انت اول ما تيجي عندك بتعمل اكزامينيشن والداتا وتشيك على كل الورك اب اللي احنا اتكلمنا عنه في الكام سلايد اللي فاتوا دول، وتحطهم في النوتس بتاعتك طبعا. وبعدين بتيجي رايح كاتب كده assessment and plan. What is your plan now? Yeah, number one, NBO. What time of that's the first question you should ask yourself. What time your patient is without NBO, not taking any food. This should this, and this patient need stat or non-stat cross match, flow cross match, or whatever you are doing in your center. And what is the dialysis now? Last dialysis, we should arrange a dialysis for your patient or no? This is the third one. What is the immunosuppression now? What is your induction and the maintenance? ATG or induction plan or basiliximab interleukin 2 inhibitor. And methylprednisone, how much you will give? 1 milligram per kg, 2 milligram per kg, or 500 according to your center protocol. And we discuss all this in details before. In steroid, I give you 3 talks for the steroids. And what is about the prophylaxis now for BGB prophylaxis? If patient allergy to Septra, what is other option with you available in your center? Atovacon, pentamidine, or Dapson? And what about prophylaxis for CMV? I told you before, if CMV mismatch, 6 months prophylaxis valganciclovir. If CMV negative, donor negative recipient, I will give acyclovir 400 BID for 3 months. Otherwise, 3 months valganciclovir, okay? CMV positive donor, negative recipient, 6 months, valganciclovir. CMV negative donor, negative recipient, acyclovir for 3 months. Other, like CMV negative donor, positive recipient, CMV positive donor, positive recipient, they will receive 3 months valganciclovir. Okay. Surgical wound, what is antibiotic I will use if allergy to unsafe or whatever? You should give vancomycin before the surgery. Just we are giving those before surgery. What else here? DVT prophylaxis, just will keep this after surgery to be decided by the surgeon. You will discuss together with the surgeon, especially you're safe to resume heparin as a subcutaneous prophylaxis or no. Home medication, what is the home medication you should continue for your patient? Your patient beta blocker, you should continue this medication, especially for a small dose of your blood pressure is soft. And the thyroid medication like hypothyroidism, you should continue this medication. And this insulin, you can give just a sliding scale insulin, and you should have protocol for this. And I think I will discuss one protocol here we are running. You can use this one in a separate talk also. And you should consent your patient. Otherwise, all other medication should be discarded now until the surgery clear plan. Post-operative management in recovery room. What you are doing in recovery room? I told you before, when you will go to recovery room, just vital sign, GCS, systemic examination, urine output, folic catheter, wound dressing, anesthesia chart, blood work in PACU, troponin, ECG if needed, ultrasound stat if needed, all this urine output, Lasix, IV fluid, this all you should play in the, you should expert what you are doing in PACU or recovery room. I told you again, we'll go first in PACU recovery room. Once I will go to recovery room, just look for what is the vital sign now, hyper, he need fluid, he need Lasix. Okay, clinically, patient stable, GCS, how much your glaucoma score for your patient? Is patient agitated, low GCS, need ICU, stable to transfer to another place, or just keep it in a recovery room or in PACU until patient will be stabilized, pain controlled, urine output, system examination, GVB, chest, heart, abdomen, wound, lower limb, pulsation. No, just you should check your pulsation in distally to be sure no ischemia or nothing after surgery. And what else? Anesthesia, you look for the chart, how much blood loss, surgical procedures, how many renal artery, renal veins, ureter, any complication, any blood loss, how much or ischemia time. This to summarize the recovery room details. You can write all this and you can just remember once you will go to the PACU. طبعا once you will go to the back because patient transfer to another service. I don't know, this is different from place to place. To admit the patient under your team again, code the status. We know already this patient, any patient transplant for resuscitation, most of the patient. Infection screening is like protocols already, just to screen any patient. But this already happened during admission, no need to repeat again. Just for the patient to optimize the patient, they usually have the problem with the bed here in ICU bed. Just try to be sure your patient is able to be transferred from ICU or intermediate ICU to a regular ward. By day one, if he's vitally stable, making good urine, no bleeding, hemoglobin is stable, nothing, ultrasound, the fluid, patient doing well, everything is okay, he can be transferred to the ward. And surgical wound, to be sure the wound is clean, nothing, no bleeding, nothing, stitch is okay, or staples is okay. Folic catheter care. Usually, sometimes that removes this folic acid post-operative day 3, like Toronto General Hospital and other hospital like San Michael Hospital and Victoria General Hospital. They removed after day 5. But after removing this catheter, you just keep this in your mind. If you have elderly man, elderly male with problem with PPH before in the past medical history, this is importance of past medical history now. And you should just start him tamsulosin 0.4 milligram daily and be sure the surgeon or transplant surgeon is okay to remove the catheter by day 3 or day 5. But usually the best is day 5. To be sure with the surgeon, no complication, need to keep this catheter longer. And once you remove the catheter, just to close monitoring by bladder scan your patient bladder to see if any residual urine or no. Pain management, usually we're prescribing acetaminophen if plus hydromorphone. Just give a small dose hydromorphone, 0.5 to 1 milligram, maybe subcutaneous, maybe intramuscular, but usually we're giving subcutaneous every 4 hours if needed, and some given IV, but better, yeah, just to give you small, don't make your patient addict, or 1 to 2 milligram per oral every 4 hours PRN if severe pain. Some patient allergy to all this, you can give tramadol already. We are giving for some patient tramadol as severe, only for severe pain and PRN, not too much already, and you don't continue more than 3 or 5 days. And usually, if you have acute pain service, just ask to monitor all this immunosuppression. For antiemetic, you should put your patient on diphenhydramine like Gravels or antiemetic, whatever, Zofran, better to put on Zofran and Dancitron, 4 milligram IV every 6 hours or every 8 hours PRN. But be sure Q2 interval. Take care from Q2 interval and prolongation. Monitoring and respiratory, just vital sign every 1 hour, 2 hours, 4 hours, and then routine. Routine means maybe every 6 hours, 8 hours. Pain, hemodynamic monitoring, arterial line and CVB to be all on target. Oxygen therapy, maintain oxygen saturation above 90% as needed. Incentive spirometry from postoperative day 1. Don't forget, the most important to prevent atelectasis and infection and pneumonia post-transplant. Just 10 times per hour while awake from day 1. Urinary catheter care, NG tube, some patient needed, and reassess postoperative event for removal, for drinking and eating. Early mobilization, postoperative day 0, bed rest, dangle legs or whatever, and postoperative day ambulate up in a chair, hallway in the room of your floor, they can walk. The same here, postoperative day 0, postoperative day 1, postoperative day 2, postoperative day 3, and you should follow all this by physiotherapy, occupational therapy, how to encourage your patient mobilization. You can take a screenshot and you can read all this because all this our automatic order for our nurses here. For diet, usually NBO initially, and just maybe clear fluid night of the surgery or the day of 0, and after that, if he's passing gas or passing bowel motion, start full fluid, then not regular diet, maybe renal diet or renal diabetic diet. This depends on the diabetes history. IV fluid can be discontinued postoperative day one. Most of the center here discontinue postoperative day two. Day zero, day one, day two, no more fluid. And by day one, you can cut down to half fluid and usually using ringer lactatic exceptives. Some patient with hyperkalemia and some patient with no urine output. Non-steroidal, except tramadol, we can use if allergy to hydromorphone or acetaminophen. As regard the progression to diet, this depends on the patient. Just they need to just from day zero clear fluid, and day one you can start a full diet and then go ahead to the regular diet, is either renal diet or diabetic renal diet. IV fluid, as we mentioned, from day zero, day one, day two, no more fluid. As we mentioned, just you can replace urine to replace one-to-one urine output. One-to-one urine output. If I'm making urine 1 liter, I will replace 1 liter ringer lactate. The best fluid they prefer, ringer lactate. But some cases I'm using normal saline if it's a little bit hypotension with no urine output and a little bit hyperkalemia. And I don't like to dialyze my patient, I will use normal saline. Why normal saline? This talk in my hyperkalemia talk before. You can go back and do to know what is the benefit of normal saline in hyperkalemia. If your patient little bit the blood pressure little bit high and no urine output little bit hyper, you can use half normal saline. Okay, and you can second day half of this urine output, and after that you can stop the flow. As I mentioned before, in the recovery room, you will do routine blood work, CBC, electrolytes, liver function, NR. And after that, you can do every 6 hours, 4 hours, this depends on your patient. You should do stat ultrasound or basic ultrasound, either postoperative day one or postoperative day three, to give you a hint or a baseline about the perfusion, any small collection for close monitoring after if any deterioration in kidney function. Venous thromboembolism, DVT prophylaxis, either sequential compression device or elastic tight stocking or heparin. This depends on the discussion with your surgeon. Medication, immunosuppression, induction, ATG, interleukin 2 inhibitor, mesalprednisone. This depends on what high risk or low risk, as we discussed before. Maintenance, tacrolimus, steroid, antibiotics, cefazolin, vancomycin, and electrolyte replacement as needed. Prophylaxis, CMV, as I told you before. And the BGB, as I mentioned for you before, CB, Septra, some center given lifelong, like Toronto General Hospital. Others they given 1 year, others given 9 months, whatever, according to your protocol. Fungal, especially with ATG and high dose steroid, you can give nystatin just for 1 month, or some center giving just during hospitalization. Peptic ulcer disease for pantoprazole or ranitidine is the best, because pantoprazole little issue with hypomagnesemia and acute chronic interstitial nephritis. Venous thromboembolism, just I mentioned before, like warfarin or in contraindication, you can compression devices needed. Blood sugar control, this depends on your patient diabetic or no. You can, if not diabetic, just check blood sugar every 6 hours. If they need it, you can put on a sliding scale, and or some center giving NPH as Humulin N or Novolin NPH. They can give in with the breakfast dose, with the morning steroid dose. Other center can give linagliptin, metformin, but currently they recommend SGLT2 inhibitor and Ozempic maybe after 1 month or 2 months or 3 months. It depends on your center protocol. And if your patient known case of diabetic and high insulin or type 1 diabetes, should be monitoring by diabetes or endocrinology. As I told you before, this is a separate linagliptin and the glycoside if needed. And hypertension, you have a lot. I just put a lot of choices for you. If your patient can take amlodipine, hydralazine, labetalol, carvedilol, or bisoprolol plus dexazosine, nitroglycerin patch, minoxidil, clonidine, all this medication we can use safely post-transplant. Lasix, if you feel your patient overloaded, you can use Lasix. Candicertan we can use after 3 months of the after graft stable. Don't forget lipids, dyslipidemia, hypercholesterolemia, and LDL. Our target should be less than 2 or 70 milligram. After one, you should start either rosuvastatin or bravastatin. We have rosuvastatin a lot. Just you can start 5 milligram, 10 milligram if your patient not on this anti-lipids. But usually started after 1 month, some centers 3 months. This depends on your center protocol. CKD management, phosphorus. Phosphorus usually low post-transplant. You know why? You ask your question why all your patients with hypophosphatemia post-transplant. The answer to replace or no now. The question, another question, to replace or no post transplant, and what is this marker for? Hypophosphatemia post transplant, hypo decrease phosphorus post transplant in your blood or decrease your serum phosphorus. This is a marker of kidney working kidney tubules or the kidney or working kidney. From because your dialysis patient have this fibroblast growth factor 23 is around a lot of this factor in your body, millions of this factor in your body are hormone, and this factor once you have increasing with decreasing GFR or no GFR, it will be increasing because it's phosphatoric, trying to decrease your phosphorus via urine. But after working kidney, after transplant, the now GFR decreasing, and no more secretion for this FGA23 and more secretion for this factor now with recovering. When phosphorus is secreted, no absorption in the proximal tubules because this factor, fibroblast growth factor 23, will block sodium phosphorus in the proximal convoluted tubules, and this will inhibit sodium phosphorus reabsorption in the proximal convoluted tubules, lead to more urine loss, and this is the cause of hypophosphatemia. But already we have a high intracellular phosphorus, or inside your intracellular is a lot of phosphorus now, so no need to replace any hypophosphatemia except if severe, like 0.2, zero point 0.3. But usually we even don't replace by phosphate tablet because it will make diarrhea worse, more diarrhea with your patient, especially with MMF or CELSEP. So we recommend just increase high phosphorus diet, and we'll come to high phosphorus diet. What is the phosphorus rich food? I will come by the end of this lecture. Another just you can give your patient vitamin D 1000, 2000 once daily, and magnesium also is a common post transplant. You can replace IV, but also by diet. After calcium, if very low, especially with parathyroidectomy, you can continue vitamin D and sometimes like calcium carbonate between meals. If you over patient hypocalcemia, and you can give 2 gram calcium gluconate as needed. And anemia for your patient like hemoglobin 77, 75, 72, 78, 80. You can check your iron saturation. If your patient depleted, just replace iron. You can give 1 gram monoferric IV. That's it. Now we have this monoferric 1 gram IV, and you can give RNS 40 units, 30 units, whatever your patient weight once, just to help his bone marrow until the kidney will be recovered. For hemodialysis line, usually we are removing post-operative day 5 or 6 for hemodialysis like tunnel line. If your kidney graft function is stable, if not, your patient is still at creatinine above 200, better to keep it until 1 month, and we'll arrange removal at outpatient. BD catheter, usually we are removing, sometimes if living kidney and working during OR, the surgeon will take it out during the surgery, but sometimes you need flushing and you need to be kept at least 1 or 2 months until we be sure the kidney function is stable, but just continue flushing every week to keep this catheter open. Pregnancy, don't forget this part. Most of us, especially the general nephrology or many of the team, just forget the pregnancy counseling post-transplant. The pregnancy should be recommended. They mentioned some 1 year, 2 years, but is the safest to be more safe is more conservative. After 2 years is the best of post transplant with stable graft function, blood pressure is controlled, minimal or no proteinuria. This is a criteria to be advise your patient to start planning for family planning or family counseling. 2 years post-transplant is the best, stable renal graft function, blood pressure controlled, minimal or no proteinuria. And just to repeat it for your young woman childbearing, just to inform you if any pregnancy happen, because we need to adjust this MMF or mycophenolate for teratogenicity or congenital anomalies after getting pregnancy. And contraception, yeah, birth control, you should all childbearing age already should use birth control methods, and either oral contraceptive or injectable hormonal contraceptive, IUDs, whatever. But better if she can use 2 methods, it will be better for her and safe for her graft. And for male also, and the male fertility and mycophenolate, Healthy Canada and FDA black box warning. just microphone. It is better to just discontinue this medication. This depends on the risk of the graft and your patient high risk and low risk. And better just to stop this medication before any planning for transplant. And sometimes you can use barrier protection for sexual activity with any pregnant partner. You should also, during your admission or planning, what is the disposition plan? Disposition means discharge plan from your hospital. You should, your patient have this medication teaching from postoperative day 1 to prepare for discharge, either postoperative day 5 or day 6. Diabetes is self-management teaching and the new diagnosis of the post-transplant diabetes, education for diet, for medication or whatever. Discharge date plan and the follow-up care will come to this. For your patient, especially for deceased donor and a non-sexual history or hepatitis C positive, either antibodies or not, what is the protocol to follow up? You can just take a screenshot for this one. Either you are doing first week, first month, 3 months, or 12 months, or 6 months. Whatever your protocol is different from place to place, but you can take a screenshot and you can fix this at least in your protocol if you don't have protocol. And we routinely monitor ultrasound every year in patient with polycystic kidney disease to see the increase in size or affecting the transplanted kidney. And maybe just either routinely no regular population, not polycystic kidney disease, we can repeat every 2 years to be sure the Doppler is okay and no incidental finding like masses or cyst or whatever. That's for ultrasound monitoring post-transplant. Ureteric stent 4 to 6 weeks to be removed. This is stent between the ureter and the bladder, and some center giving prophylaxis, ciprofloxacin, like Toronto General, 500 BID for 2 days, beginning morning of stent removal. This will be prescribed to just continue for 2 days. Okay, just for a UTI prophylaxis after stent removal. And vaccination post-transplant, you should, every clinic visit, you should recommend flu vaccine yearly, COVID vaccine every 6 months, but be sure your patient didn't receive any live vaccines and another vaccine according to the age and according to your vaccination program. Skin cancer, you should educate your patient about avoid sun exposure and sunscreen protection, and you should have dermatology for your patient for annual skin screening for any skin cancer. Don't forget this part. And this link here, online library for skin cancer risk for transplant prediction tools for post-transplant patient. To preview, if you like, you can copy this link and you can expect your patient skin cancer. Some patient post-transplant with low potassium after working kidney or whatever. What is the high potassium? Every one of nephrologists now know high potassium food, including fruits, vegetables, and nuts, proteins, others. All this, no list, you can just copy paste and keep in your mobile or your WhatsApp. Or if you have patient with hypokalemia, you should advise your patient for this, especially for banana, any citrus or juice, dried fruits also, and another a lot of potatoes here, and beans, lentils, almond, salmon, chicken, coconut, and avocado. All this with high potassium, high magnesium. Also, most of the transplant around 99% with hypomagnesemia. Just vegetables, green leafy vegetables like Spanish and other beans, lentils, and soy containing foods. And almond, like pumpkins also all this containing magnesium, just vegetable and nuts also this containing high magnesium. The most problematic one is the phosphorus now, because most of our transplants nephrologists don't replace phosphorus as the mechanism I explained before. What is the most important? High phosphorus diet. Everyone know milky dairy product, cheese, yogurt, and the protein, meats, poultry, fish, eggs, and another nuts, especially nuts, a lot high phosphorus already with dairy product and meats. And all this you should explain and educate your patient to just increase phosphorus diet. Anemia, workup post transplant, just in regular as any anemias, iron studies for iron saturation, B12, TSH, and serum protein electrophoresis if elderly patient already. Hemolytic workup if you suspect hemolysis. CBC with peripheral smear, LDH, haptoglobulin reticulocytic count, UTI prophylaxis, especially for female with recurrent UTI. Don't forget this estrogen كريمز like فاجيفيم ده 10 microgram intravaginal daily for 2 weeks, then twice weekly ongoing plus treatment of the current UTI. 1 year بوست ترانسبلانت كير تشيك ليست. ايه اللي انت هتتابعه لو عيان عندك بعد سنه من الترانسبلانت؟ الكدني فانكشن بتاعك، بتشوف الكرياتينين واليورين اوت بوت واليورين بروتين، ورينا الالترا ساوند فولو اب، اميونو سبريشن ميديكيشن، ادهرنس دوز ادجستمنت اند ليفل، اند انذر سي بي سي، الكترولايت، كالسيوم، فوسفورس، بلاد بريشر، كارديوفاسكولار. انا عايزك تاخد دي سكرين شوت وتعملها في العياده عندك. دي الحاجات اللي بتتابعها مع كل عيان ترانسبلانت. اساس دايما الدايابيتس والبلاد بريشر، ما تقوليش حد هيتابعهم غيرك يعني. فانت لو انت شغال في بلادنا العربيه طبعا انت المفروض تماند الاثنين دولت، بلاد بريشر ودايابيتس وديسليبيديميا وسموكين واسبرين والحاجات دي كلها. الكارديو فاسكولار ريسك ده المفروض ان تعمل له كنترول من العياده عندك. والدايابيتس طبعا دلوقتي انت لازم يكون معظم العيانين عندك الكرونيك اللي هم بعد سنه دول معظمهم يكونوا على الاس جي ليتي انهبيتورز او الاوزومبيك على حسب البادي ويت والدايابيتس ستاتس بتاعتهم. انفكشوس مونيتورنج بي كي فيروس، خليك متابع المصيبه ديت لان ممكن يحصل له رياكتيفيشن ات اني تايم. بون مينرال ميتابوليزم خليه باند عندك في العياده برضه، الكالسيوم والفوسفورس والمغنيسيوم والالبوم والكلام ده كله. ما تنساش immunological مونيتورنج دي اس اي، لو عندك رايزن كرياتينين عندك هاي ريسك دونر حاول تعمل له كل مدى كده دي اس اي تطمن ان الدنيا تمام. ديرماتولوجي وسكين سكريننج، ممكن تعمل تتابع العيان بتاعك وتعمل له اكزامينشن. السكين فول سكين انيوال سكريننج، اني ابنورمال ماش والليزن يشود تيك اكزيشن اند فور هيستوباثولوجي. وفي الميل بي اس اي فيكا لوكال بلاد فيت سكريننج، كل ده المفروض يتعملوا كل سنتين. الفيميل عندك باب سمير والماموجرام برضو نفس الكلام، ما تنساش الحاجات دي كلها لازم تتعمل كل سنتين. بروفلاكسس فاكسين زي ما قلت لك، فلو فاكسين ييرلي، عندك كوفيد فاكسين افري 6 مانثs، عند اذر نيموكوكال فاكسين لو اكتر من 65 سنه والكلام ده كله. ديت للعيان هم الكورونيك ترانسبلانت، خلي دي عندك في العياده عندك، خدها اعملها عندك في العياده. وما تستناش من الدعاء يا عم ديت يعني ايه. انت ما تفوتش حاجه في العيان بتاعك، وما تخليش حد يعلق عليك، وما تخليش حد يعلم عليك، سواء كنت شغال حتى لو كنت شغال في كفر بطيخ على رأي واحد زميلنا اسمه دكتور هشام. 1 مانث بوست ترانسبلانت كير تشيك ليست. بعد شهر بتتابعي برضه. قلنا زي ما قلنا الكدني فانكشن اهم حاجه عندك، بتبص على الكرياتينين والتكرول والامينو سبريشن ليفل عموما، ما تنساش الحته دي. وعندك اليورين بروتين والرينال الترا ساوند، ما تنساش دولت. الكترولايتس وبلاد شوجر وكالسيوم وفوسفورس ومغنيسيوم، اميونو سبريشن والليفل بتاع الميديكيشن والادهرنس والدوز ادجستمنت والكلام ده كله. فيرال بروفلاكسس، هل هو خلص البي جي بي بروفلاكسس ولا لا؟ هل هو على سيمي في بروفلاكسس ولا لا؟ الووند اكسس والمونيتورنج، السيرجيكال ووند الوند بتاعه كويس، الاستيبل اتشالت، الستنت، اوعى تنسى الستنت، اوعى تنسى دياليسيس كسر في العيان، اوعى تنسى فيميل يانج تشايلد بيرنج بيريود، وما تنساش تعمل لها كونسل البريجنسي وتعرفك وتكون ماشي على كونتراسبشن. تمام. الكارديوفاسكولار اوعى تنسى الهايبرتنشن والدايابيتس والديسليبيديميا، لازم تعمل لهم كنترول، وما تخليش حد يعلق عليك، وما تنساش هتأذي بقى المريض بتاعك. وخليك صادق مع المريض كده واخلص لله، وان شاء الله تسلك معاك. انيميا والمونيتورنج والكلام ده كله، تابع برضو الانيميا بتاعتك، ولو حصل اي حاجه تتابع وتشوف العيان محتاج بون مارو بايوبسي ولا مش، ولا محتاج ايرون، ولا محتاج ارانيزب، ولا محتاج يتعمل له ورك اب، وشوف الدنيا ماشيه معاك ازاي. دايابيتس سكريننج طبعا، بلاد جلوكوز والهيموجلوبين 1 سي ممكن تعملهم. لو العيان مش دايابيتك ممكن كل 6 شهور، كل سنه، على حسب مقدره المريض. من 1 لشهرين بوست ترانسبلانت كير، حطها عندك برضو في العياده. وما تنسناش من الدعاء. تمام، وان شاء الله خير. المهم دايما تحط برضو البارامتر، نفس البارامتر تقريبا اللي اتكلمنا عنها قبل كده، تخلي كل البارامتر دي عندك في العياده عندك للمريض بعد شهر، بعد من شهر لسنه، وبعد سنه على طول هتابع ايه في العيان بتاعي. بص يا سيدي، والبي ام دي اللي هي البون مينرال دينستي ما تنساش، بتاعت الاستوبروزيس ده برضه. بص ترانسبلانت كلينيك فولو اب ده خليه عندك برضه، لو انت برضه بتتابع عيان من اول يوم او من اول اسبوع او من اول شهر والكلام ده كله. الكلينيك فولو اب فيرست شهر، فيرست مانث، فيرست شهر صحيح، فيرست مانث ات ويل بي ويكلي 1 تو 2 مانثs افري 2 ويكس والكلام ده كله. وترتب ديت وان بروتوكول انت تظبطها على حسب مقدرتك عندك برضه. ده يعني من الناس اللي عندهم ريسورس وعندهم فاسيلتي. وطبعا في ده في كندا بقى، انت شوف على حسب الظروف عندك، حاول يعني تقرب من الجدول ده وتظبط انت لنفسك في المكان اللي انت فيه، في السنتر، في العياده، في المستشفى، في المكان اللي انت فيه، تعمل بروتوكول لنفسك. وده البلاد وورك بيعملوه هنا مثلا فيرست 3 مانثs توايس ا ويك، انت برضو ماندي وزارس داي. انت برضو بعد كده بتقلل لغايه ما يوصل 3 لافري 3 مانثs. انت بتقلل على حسب برضو الريسورس والمكان بتاعك والامكانيات اللي عندك. البي كي فيروس سكريننج بيعملوه في اول عند اول مانس وثاني مانس وثالث مانس، وبعد كده ايه من كل 3 مانس، يعني كل 3 شهور في السنتين، وبعدين من 2 تو 5 years. المهم انت حاول برضو تشوف الاخر جايد لاين وتتابعها، وتتابع برضو تعمل لنفسك بروتوكول عندك في العياده عندك. اتمنى يا رب تكون استفدت اليوم، وان شاء الله ما تقلقوش لسه، انا ما مش هسيب حاجه ان شاء الله ما اتعلمتها في كندا لما انقلها هناك لخدمه الاسلام والمسلمين باذن الله، وبنيه علم ينتفع به. وان شاء الله يكون كل واحد بيتابع مريض زارع كلى، ما لا انت عارف المريض ده طبعا عانى في الدياليسيس. المريض ده يعني دفع دم قلبه على ما وصل لموضوع الترانسبلانت. المريض ده دفع من صحته على ما يعني عمل عملية والاميونو سبريشن اللي عمال يدفع فيها دم قلبه، وفي الاخر مثلا ما يكونش فيه بري ترانسبلانت اسسمنت كويس، ما عملتلوش تقييم كويس، مزد اي حاجه بعد الترانسبلانت. الحاجات دي، كل التريكات ديت انا مش هسيبك، انا معاكم في الترانسبلانت ده، في الدايره بتاعت البري ترانسبلانت. بعد كده احنا لسه موالنا طويله في الترانسبلانت، بلاوي لسه في الترانسبلانت هقول لكم عليها. والكومبليكيشن بقى من الريجكشن للانفكشن للميتابوليك للي مش عارف ايه ليه. والبلازما فاريسيس، في اخ من الزملاء طلب موضوع البلازما فاريسيس. انا هديك البلازما فاريسيس زي ما بص يعني، بص من اقوى الناس في كندا هنا مقدمينها، انا هجيبها لك على طبق من فضه. يعني الحاجات دي كلها انا يعني ان شاء الله انا كل نيتي من القناه دي كلها ان انا انقل لك كل معلومه اتعلمتها هنا، علشان الجهل اللي انا شفته عند في بلادنا يعني عموما يعني. وعلشان عموما يعني ما كانش في فرصه في الواحد يتعلم في مكان كويس، فالواحد بيحاول يوصل معلومه تخدمه بقى الناس الغلابه، وناخده بقى دعوه من مريض. يعني انت كل دعوه تاخدها يعني بالمعلومه باي فايده من المحاضرات اللي احنا عملناها ديت، ان شاء الله هتوصل للواحد باذن الله. ويا رب دايما ما تنسونا من الدعاء بالصحه والعافيه والستر والبركه والتوفيق، تمام. ولا تنسوا دائما الصلاه والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ولا تنسونا دايما من صالح الدعاء، ونلقاكم في رعاية الله وحفظه، والسلام عليكم ورحمة الله وبركاته. ومع بداية الترانسبلانت، أنا لسه ما دخلتش في مواضيع تماما. أنا عندي 2 لابتوب، كل لابتوب محمل بملايين المحاضرات، ما سبتش مستشفى فيك يا تورونتو، ما شفت ما سبتش ستاف فيك يا تورونتو الا ما خدت كل ما يملك. فان شاء الله نحاول هنقول لك كل الكلام ده، بس ادعوا لي بالبركه في الصحه في الصحه والعافيه والساتر والوقت ان شاء الله، ونحاول نقول لكم كل الكلام ده بكل بساطه وكل البروتوكولات. وهنحاول نعملها لكم فيديوهات يعني بحيث انت تخش على الحاجه اللي انت عايزها بعد كده. بس انا حبيت الم الموضوع ده النهارده لان كان فيه معلومات كتير، فحبيت احطهم في وان فيديو. وان شاء الله باذن الله يعني اللي محتاج حاجه يكتب في الكومنت، اللي عايز اي حاجه علق لنا في التعليقات. وشوفوا انتوا عايزين ايه وقولوا لي، اللي عايز حاجه يقول لي عليها، بس يعني خليكم معايا لان الحته دي انا بستفاد، يعني زي ما انتوا بتستفادوا انا بستفاد اني بثبت المعلومه. انا بستفاد ان ما يعني ما لا يعني بالظبط كده، اللي مش يعني اللي هياخد علم ويجتنزه لنفسه ده يبقى يقابلني، يبقى ينفعه بقى في القبر ان شاء الله، او ينفعه في الدنيا لانه اصلا كده كده هينساه، او كده كده هيروح منه. فاللي مش هينشر العلم يا جماعه والله ولا علمه هيزيد، ولا هو هيزيد وهيتم محلك سر، ولا هيبقى منه فايدة لا دنيا ولا آخرة يعني. فنسأل الله أن يكون هذا علم ينتفع به أي حد يستفيد منه في حياتنا ومماتنا. ودايما ببركة المصطفى صلى الله عليه وسلم وعيد ميلاد المصطفى، نسألكم دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد، والسلام عليكم ورحمة الله وبركاته، وآسف على الإطالة. ونلقاكم بفيديوهات كثيرة إن شاء الله بإذن الله، وبننقل لكم كل ما تعلمتم في كندا لخدمة الإسلام والمسلمين وجميع المرضى عموما. ونشوفكم على خير إن شاء الله، والسلام عليكم ورحمة الله وبركاته، وآسف على الإطالة، السلام عليكم.